Recording in progress.
Howdy and welcome back, everybody out there. Glad to have everybody tuning in. Welcome back to The Broken Brain. This is Dwight, your host, and I'm always super happy to have any returning guests, returning champions who come back to the program, and I'm very excited today to be joined by Shari Corbitt, coming back again to the program. Hi, Shari.
Hi, Dwight. Thank you so much for having me back. I really appreciate it.
Oh, I'm thrilled. I'm thrilled to have you on and to talk about this as well. I was trying to remember, and I would have looked if I was more professional. I think it was was it back in 2021?
It was. I believe the last time we spoke was almost exactly 2 years ago.
It was. Okay. Yeah. And so for those who haven't heard that episode, go back and check out that classic episode, July of 2021, when Dr. Corbitt had come on before. You are the director of Awakenings Treatment Center, where you work with complex trauma, PTSD, eating disorders. Chronic pain is also a big deal there, right? Of what you guys do.
I believe the last time we spoke, we talked quite a bit about the intersection between trauma, grief, and loss.
Yes.
Chronic pain, which is really complicated for people oftentimes to understand.
It's one that I know because I know the category it's in. That category of topics in the podcasting gets a lot of listens. I mean, people are really, especially when chronic pain intersects with so many things, sobriety, trauma, all of that kind of stuff. And oftentimes it goes along with the trauma that inflicts things that cause PTSD.
Exactly. 100%. Yeah.
Well, I was fascinated to hear what you're doing, the work and the research and the things that we're going to talk about today has to do with psychosis that can be related to or triggered by or probably lots of other relational words we can use. We'll get into those about psychosis, right?
Yes.
Yeah. And wait, did I say psychosis twice? I don't think I said cannabis. Psychosis.
Oh, that's all right.
Psychosis that's triggered by psychosis. That's a great topic. No, but is triggered by cannabis or influenced or related to cannabis use, right?
Yeah. Over the last 10 to 12 years, even prior to the legalization in many states, we started to see an uptick in individuals coming for treatment for different psychotic disorders, schizophrenia, schizoaffective disorder, who didn't seem to have a history of it in their family, which is unusual. And so we started noticing that we seemed to have some common denominators, and one of them was a history of heavy, chronic marijuana use. And that, at first, that was still sort of a big question mark. And then in the intervening years and during the past decade, it's become more and more obvious. And now there's much more research related to the relationship between the two.
It's interesting as things have gone more, as there's been more openness to marijuana-based research, medical marijuana use, recreational, also being available in, I didn't look it up, but several states now have at least medical, if not medical and recreational use legalized. So you got different sides of that coin. When you do research, you'll find things. And it's not always things like, oh, it's awesome. That's not always what you find. Also, a lot of discussions. And I had just said as we were starting to record, that many people will take legality as the reason or one of the big reasons of whether or not they should use something. That's there's a lot of people who get off of drug use will gravitate towards alcohol use because unless you get a DUI or commit some crime while you're drunk, you're not going to get charged for using alcohol. But that doesn't mean that someone with a history of addiction should drink alcohol just because it's legal.
Exactly.
Yeah. And so kind of when things are allowed, we can go, woo, and just kind of get excited. And so anyway, so balancing this out with what it means for mental health is, pretty big.
There's no doubt that there are profoundly helpful medicinal uses of marijuana. I don't think anyone that's been paying attention would argue that someone, for example, with cancer-related pain oftentimes may benefit from using marijuana versus opiates, given the slew of side effects that from opiates. But that's a very small part of the population, of course, and that's not what we're seeing. So really having a focus on this is so important, because oftentimes people will come in having had their first, second, or third psychotic break, which is what we call it when someone begins having hallucinations, delusional thinking, really having difficulty staying connected to moment reality. Their family wants to do everything possible to support their care. And so there will be medication, there will be group therapy, individual therapy. But if there isn't a focus on the importance of abstaining from marijuana, particularly the high concentrates of marijuana, the person will frequently be right back in the same situation. The problem with that progression is that the psychotic breaks become more intense, and the time it takes for a person to clear, which is what we call it when the delusions and the hallucinations subside, becomes longer and longer. And so we'll often see someone for whom we may be their third or fourth treatment episode. Family will confirm that, gosh, last time this happened, our daughter, seemed back to herself in 2 or 3 weeks, but this time it seems like it's been 2 or 3 months. Wow. And so this is a really important topic for families to have an understanding of.
Yeah. Well, let's tell people a little bit about that. When you say to clear, what's the definition of so obviously a psychotic break is a removal from reality in one form or another. And that can be hallucination. And I guess for anyone out there who's not familiar, right, you can correct me. Hallucination is when you see or hear or feel something that is not there, that others cannot see, hear, or feel. And delusion is usually more of an underlying belief. So
exactly. Yeah. Delusions are thought-based, so they can be a paranoid thought that someone is being observed, or they can be fear-based, or oftentimes a persecution fear. Whereas, as you said, hallucinations are seeing things that other people are not seeing. Right. Oftentimes with cannabis-induced psychosis, we see what we call tactile hallucinations, which is feeling like a crawling feeling on the skin, or that something's underneath the skin, something like that. So these are two distinct and separate symptoms, the delusions and the hallucinations. To answer your question, the clearing of them is oftentimes a subsiding of perhaps thinking someone on the television is speaking to you directly, or feeling like that sense that I just described, that something's crawling on your skin. So those may subside. Unfortunately, the delusional symptoms oftentimes become more fixed. So if someone begins to have a fearful thought process that they're being persecuted, for example, even when the hallucinations subside, oftentimes the delusional process may not subside. There's also a third symptom that's very important to discuss, which is anytime a person experiences psychosis, there's often harm to their cognitive processes, their ability to think, not just to think clearly, but to think critically, to think abstractly, to have complex thought. So someone that may have been very bright, whether it was related to academics or not, someone that was clearly a very, an intelligent person or average intelligence previously, will typically experience what is called significant cognitive decline. It's a mouthful, but that's a devastating symptom.
It's a very devastating mouthful, right?
Yeah. And so that's a third component. We call the delusions and the hallucinations, unfortunately, are called positive symptoms of psychosis, where the cognitive decline and the the more subtle symptoms that can be harder to pinpoint are called the negative symptoms.
Yeah,
little bit of a strange dichotomy.
Absolutely. A lot of people out there may or may not know, like in a lot of psychological or research terms, and we're talking about this, especially behavioral psychology does this too, when they talk about reinforcement. Positive means adding and negative means subtracting, taking away from, right? So
exactly.
If I'm losing cognitive function, it's negative. If I'm seeing something new, that's a nice spin on a hallucination. I'm seeing something new. Makes it sound so positive. So there you go. Yeah. But no, it's I could be seeing something that is very negative in the way that we would usually use the term negative, but it is a positive symptom because it's appeared. It's a new one. Yeah. So now, that longevity. Oh, I just wanted to clarify real quick. When you talk about that significant potential cognitive decline, that you're talking about, that is in reaction to having more frequent or longer incidents of psychosis tends to contribute to that, is what we're talking about, going through psychosis more and more, which is possibly triggered by the cannabis use, is what we're talking about. Gotcha.
Exactly. And there's a whole form of treatment for people that struggle with ongoing psychosis called cognitive remediation. And that form of treatment is available to try to mitigate against the effects of cognitive decline. So that's getting a little bit deeper into the weeds.
Absolutely.
But there are treatments for all of the different aspects of this.
Yeah. And weeds is not a pun necessarily, everybody out there, just so you know.
Sorry. Yeah.
No,
that went right past me.
Sorry. No, that was you being normal and me being stupid. For some reason, it pops in my head. And speaking of compulsions, we can do an episode on compulsive use of humor. Anyway, but no, it's a terrifying process. Jumping back into the real seriousness of this, it's terrifying to have to question one's own reality. At the same time, I'm thinking those that have already experienced symptoms of psychosis are definitely more likely to gravitate towards things that would usually alleviate stress. Have a drink, smoke a joint, or maybe even, maybe even with a prescription, depending on where they are and what the criteria are in that state. To use alcohol, marijuana, cigarettes. Very hard for many people to quit when they have psychotic disorders because for some reason the stimulant of tobacco seems like it helps, or they think it does, and enough that it shortens lifespans. So they're at risk for overuse of intoxicants and psychoactive substances anyway, right?
Absolutely, that's true. And there's a lot of research being done in this area now, because what isn't clear, although it appears that the chronic use of high test, if you will, high concentrate THC waxes, oils, appears to be causing these much higher prevalence of psychotic breaks, it really isn't entirely clear if that causality is what it appears to be, or if people that are vulnerable to psychosis are finding marijuana more attractive. So it may be causal in the other direction. And so it may just appear to be the marijuana, high concentrate marijuana causing psychosis. However, I will say, and this is not research based, I want to be really clear, that having worked in the field for decades now, we never saw this common denominator prior because waxes and oils were not available. Yeah. And so we did not tend to see people with no psychiatric history in their family whatsoever, even upon thoughtful processing of maybe Aunt Sally, Uncle John, he was never diagnosed. Actually, he does appear to, even when that is a thoughtful process, in my clinical experience, I've never seen this before, where almost every individual that's coming in with a psychotic break has a history of chronically using high intensity THC.
Wow. So there's a lot going on there in that. So from a research standpoint, we're very much at the investigating correlation to try to narrow down causation.
Exactly.
At the engaged, like frontline clinical care level, you're definitely seeing it. So,
We're seeing it.
And that was my question that I forgot to ask in my mishmash of statements a minute ago was, and I think you're answering it there, which is, do you see this more prevalent with people who have already had a history? But from what you just said, I'm taking that to mean not necessarily. It's not necessarily just a problem for those who've already had a break, but.
Yeah. Exactly. And it's very hard to pinpoint because in our area in Southern California, a lot of the clients that are coming to us are between the ages of 18 and 25 when a person might be experiencing their first psychotic break anyway. But what we're finding is that when we're able to really get honest, when family members are able to really get honest about what their adult child has been doing, there's often been a heavy use of marijuana since early teens or mid-teens. So we are very careful not to try to state a clear causality because the research isn't there yet. And there, like I said before, there's a lot of research being done in this area.
But, there's a lot of things that we do, varying degrees of research and things that are just kind of standard operating procedure. I mean, people are having great results from like ketamine infused therapy. There's been lots of research in that, but when that started, some people, will say, well, that's an off-label use for that. It isn't designed for that.
Yeah.
It's like, yeah, but that's true for a lot of antidepressants. So we use them anyway.
Absolutely.
Because sometimes of correlation, and there's other cautions. And I'm surprised, by the way, because I've always been told this. When someone has a problem with ongoing anxiety, one of the first things that they often are told, but unfortunately often or not, is take whatever amount of caffeine you're using and cut it, significantly if you can't get rid of it altogether, because that contributes to anxiety all by itself, right? So
absolutely,
all sorts of best practice things, right?
Yeah, absolutely. People with anxiety disorders and sleep disorders are strongly encouraged. And to your point, Dwight, what is so interesting is that oftentimes people with anxiety disorders are highly attracted to stimulants, which is confusing on its face. It's confusing. And just as people with depressive disorders are often highly attracted to depressants, like alcohol being the primary one.
Yeah, that's interesting.
So it is interesting, and it's really an ongoing learning process from a research perspective, from being a frontline clinician, because at the end of the day, if someone is attracted to a substance, they are undoubtedly achieving some reaction from that substance that is helpful. And we always are seeking to support that individual in meeting that need from a healthier standpoint, whether it's physical activity or meditation or self-hypnosis or whatever it may be.
Well, and that generally speaking too, if we view any kind of psychoactive substance, whether it's abusive, whether we consider it problematic or not problematic, if I gravitate to it, it's always good to see because the underlying need is generally healthy. It's just how do we get there, right? If I'm trying to find, and it's funny.
Absolutely.
As you say that too, it's funny. I just realized I've thought this before on purpose. That's why I do it. But over the years, I've started investigating for people who tend to gravitate to stimulants, even if they come in for like, whatever reason, drug and alcohol, kind of abuse reasons, or even just something else, but it comes up that they use a lot of caffeine or when and if they use drugs, they go for uppers. I've started that immediately as a little note in my head to screen for ADHD. Right. And that's just a little connection that you notice over time is like, well,
absolutely,
the medication is stimulant based. So are you craving for something you need, right? And has there's a better way to get it, usually.
Yeah. And directly related to this, from the clinical treatment perspective, wanting always to approach every person with a deep regard for respect and compassion, if you're working together to support diminishing the anxiety and an individual feels supported, they're going to be much more willing to explore the options that are recommended. So if you're both working toward, like in this example, diminishing anxiety versus, it was a bad thing that you abused this substance. That was you were a bad girl or a bad boy. But if, as opposed to that, really working together with, what, this substance was doing something for you.
Right.
Ultimately, it's creating consequences or it's diminishing your health in other ways. But let's honor the fact that you were trying to do something productive. You just found a path that ultimately wasn't serving your highest good.
And one of the things I was curious about is, do people ever seem to, or do they often seem to pick up on this connection on their own? Because if I'm having a really hard time or, and it's like, well, yeah, maybe I use marijuana here and there, either recreationally or because I think it'll help me.
Sure.
But I'm having new bouts of psychosis. I don't know that my first thought would be like, I bet it's marijuana, because I don't know that I would think that.
Dwight, that's such a great question, because the answer to that is really interesting to me. The answer is, not only does the person themselves rarely, if ever, connect the dots, but their family members do not. And so we have so many families. We have a Monday evening family support group every Monday night here at Awakenings. And the parents show up, the spouses show up saying, we have to get to the bottom of this. We have no idea what's going on. And thank goodness we don't have to deal with addiction. And I'll often look at them and then it occurs to me, oh my goodness, they do not have a sense yet that more than likely this was entirely driven by the chronic wax pen, by the concentrates. And trying to educate about that and talk about it is often much more contentious than you might imagine. Because if I have a loved one who's struggling and I'm desperate for them to get help, I'm going to want to hear any possibility. But at least at this point in history, marijuana is really being perceived as healthier than other things. It's really, it's all natural. It's healthy. It's not going to give you liver disease like alcohol will, and so on and so forth. And so there's some misconceptions that we've really been bumping up against. Mm-hmm. Ultimately, the education works because, of course, at the end of the day, people just want their loved ones to feel better and to be able to function.
Absolutely. Well, and I think that there's a whole little minefield there, isn't there, of different issues that you run into, because you've got the attachment that someone has to, hey, whoa, this is my coping skill, and that
exactly
that can be attached to anything. I mean, certainly with addiction, and dependence, which we can see that even with cannabis use, although it didn't traditionally we don't talk about those things as much. People think. But you even if you're not as chemically addicted to cannabis, you are definitely addicted to the results of it many times. People can be.
Yeah.
And all the way down to, if my doctor says, hey, you're pre-diabetic, lay off the sugar. Just think about anybody out there who doesn't quite get, maybe, like if you've never been addicted and you don't view that.
Yeah.
Just look at it. And even if I'm a casual user of marijuana, I'm going to pretend like it was I have a conversation with my doctor and then I just walk out the door and I'm fine not having ice cream ever again.
Right. Yeah, not likely.
People usually work. Yeah.
Not likely at all. And all of the self-care, in fact, in the 12-step communities, certainly that metaphor of diabetes is used frequently, mm-hmm. because the notion that someone with diabetes will just sort of snap to it and follow the recommendation is ludicrous, because we have powerful emotional connections to the things that give us comfort and to the processes and substances that bring us comfort.
How do you respond because the thing that I see that people have been happy about, clients I've worked with who use marijuana and maybe have for a long time. And they maybe even use it like you would medicinally, even when it was illegal. They'd take a little bit, smoke a little bit, or they'd go somewhere where it was legal enough and get gummies or something. And they would use it. And now that it's legalized, they have this feeling of, great, here's this thing. You use the phrase better than, right? So it's better than alcohol recreationally. I'd say with some qualifiers, sure, there's some truth to that. It's better than opiates. Okay, probably you can make a case there. It's better than, now here's a tricky one, anxiety medication. Well, I would only say that a lot of clients I've worked with, and some of them seem to be functioning quite well, do better with that than they do with some antidepressants or anxiety things. And so it's a hard sell.
It really is. And to your point about, do clients see the connection? To your point about that, there is strong evidence that there's a powerful rebound effect of anxiety when people who are not daily smokers or daily consumers of THC take a break, that there's a very powerful rebound of anxiety. And so that is also true of other anxiolytics. So I'm not pointing to THC as a standalone in that. But anytime we're using a substance to calm our anxiety, neurologically, the likelihood is that when we stop using that substance, the rebound is going to be extremely uncomfortable.
Yeah.
Gotcha. That can sort of lead into a whole nother conversation, but certainly for anxiety, for a lot of mental health issues, the behaviors that we can do that are not medicinal in general are going to be more helpful in a sustainable way.
It's interesting when you point that out. Yeah, because even just the absence of a period, if it's like I get used to every so often I sit down and zone with a psychoactive substance, even that, the absence of that will be like, well, this evening I have to put up with all the little irritants and things around me or the concerns. So even that would feel like a rebound, even if it's not necessarily new or anything. It's just that I'm missing that now. So when people do, is part of this trying to, along with the education, trying to replace that with something else to say, okay, we need to give you other tools so that you don't just keep wow, geez, now I know that it might be triggering my psychosis or contributing to it, but I can't. What am I going to do instead? I still need to go to sleep tonight. Yeah.
Absolutely. Absolutely. Well, it's a complex treatment approach. The experience of having a psychotic episode is terrifying. Yeah. So one of the first things that is important in terms of a treatment approach is the group therapeutic experience, so that people can be with peers going through a similar or having gone through a similar experience previously, so that first and foremost, they know they're not alone and that help is available. And so that group process is so important. And then above and beyond that, we really incorporate and feel that physical movement is critically important. That having been said, different activities resonate for different people. So we don't expect everyone to jump into a yoga class and be thrilled about it. We provide a whole variety of different activities so that people can really start to get a sense of what they enjoy. What we always tell clients is, at the end of the day, what you are going to continue to do is something that you enjoy. Yeah. So we provide strength training. We provide more sort of stereotypical cardiovascular activity like elliptical and treadmill and cycling, and then yoga as well, but all different types of yoga, so that we've exposed clients to a variety of options. But physical movement for our folks is just critical. And then what we would expect as well, individual psychotherapy to address thought distortions, family therapy to address what might be going on in the family. It gets, it's never ending complexity. Yeah. So we have to get our arms around as much of that as we can.
Right. Absolutely. Well, So when you're talking about the high potency, and it sounds like that's one of the things that has maybe kickstarted all this, is now there's there's like what, different sizes and flavors, and now that it's a product, right? That you'll find for commercialized products are going to have lots of different variations, and what would you consider to be high potency? What are we talking about there? Any fields for that?
Well, the general definition of high potency is anything that is 20% or above THC concentrate. That having been said, there's a huge leap when you leap to the wax and oil concentrates. Those are oftentimes between 82 and over 99% THC. So sort of commonsensically, it doesn't surprise me that we might see some type of psychological phenomenon. Makes sense to me that would be the case, the same way that when people are drinking beer and wine versus drinking old school moonshine, they're going to have different physical repercussions,
or even more higher proof liquors, of course, right? Would be even if it comes off the top shelf, so to speak. It's like
absolutely because
high
someone
proof whiskey
is
definitely different than having a beer on your lawn, right?
Exactly. So certainly, depending on someone's vulnerability psychologically, it can all become detrimental. But when you're talking about the waxes and the oils and the high concentrates, it's just a whole nother situation in terms of psychological ramifications.
Yeah. Now, I know that when we talk about medicinal, like prescriptive marijuana, or at least a medical card to be allowed to use it, in a lot of states, I know in the state that I'm in, they do not allow that for simply anxiety, which a lot of people tend to use marijuana when they have anxiety symptoms. But they do approve it for trauma. If someone has a PTSD diagnosis, they're allowed to get it. I'm curious, with trauma and anxiety and PTSD being so high, is there what's the risk there, or is it any greater or lesser than anybody else, as far as PTSD being something that like a doctor might issue a card or recommend even, that can be helped by some kind of psychedelics or another one, or from marijuana. Do you see extra risk there, or no more than anybody else?
No more than anyone else. In fact, it's often a larger conversation to discuss with someone, particularly someone that wants to come into a treatment center where it's an evidence-based facility, that in order to address their symptoms of PTSD, for example, on a path that's seeking resolution of the symptoms, not a medicinal treatment of the symptoms. So, for example, if we want to resolve entirely someone's hypervigilance and sort of their extreme startle response, fear of being out in the world, we're actually going to need them to be stone cold sober, if you will. And that's very uncomfortable. I mean, if someone's already dealing with all these symptoms, now that doesn't mean that they can't be taking a medication, perhaps a sleeping medication or something like that. We can't be softening the symptoms of PTSD and then trying to treat them adequately. And it's a difficult juxtaposition, because you're asking, knowing that in the long run, it's going to be a huge home run. It requires a lot of support to keep someone in a place where they're willing to put themselves through that.
Right. Yeah. And that's where like a treatment center, is kind of a different thing, and can also give people that opportunity, because you got in most inpatient stays. In fact, I'll say, virtually all inpatient stays, if you go to a psychiatric unit on a hospital, they're going to at least evaluate whatever medication you're already on. And in some cases, I've known longer term programs will start by under the direction of a doctor and psychiatrists and such, will actually say, how much can we just stop taking and see what happens, or wean off of and see what happens?
Yeah.
Because you come in with 2 or 3 meds and we don't know if they're right.
Absolutely.
How do we know? Yeah.
Yeah, that can be a very productive process when oftentimes people have they've been trying to get help, and they've gone to one doctor and then they've gone to another doctor. And if they've gone to even maybe multiple treatment centers, oftentimes a telltale sign of that is that the list of medications will be just sort of patently ridiculous.
Yeah.
And so what you just described, they will call that a medication washout. And oftentimes that washout, not only is it safer to do that with supervision and support, but very productive, because then you can really start from, okay, what is this person's baseline? What does their sleep look like? What does their appetite look like? What does their mood look like when they're not taking anything and they are surrounded by support? Because we always want a person to be taking the least amount of medication possible for the benefit that they need. Mm-hmm. So it's not an anti-medication perspective by any means, but we want people to be piling on the side effects, which of course are substantial. So it's a medication washout. We are a big fan of that, and we really support people in doing that. So we really can determine with the right support over an extended period of time, what's the least amount of medication someone can be on to function really well and to feel good?
Yeah.
Most importantly, to feel really solid within themselves.
So, and once again, it's all very individualized, but when we're talking about things, and even research isn't universal, but it is good to know these trends. I had been reading a little bit of in preparation for this, some of the stuff that you had shared with me. And where is it in here somewhere? There was some indication, some of the research maybe shows that, oh, here we go. Regular use of high potency cannabis, which you just defined for us, can make people up to 5 times more likely to develop psychosis. And is that, like you said earlier, regardless of their history with psychosis?
That's what we're seeing. But again, we can't put an absolute period on the end of the sentence yet, because it's unclear, even if someone has not had a psychotic break previously, if they may have developed it and they may be more attracted to cannabis as a result of that vulnerability. So we don't know the directionality just yet. But when we see this in younger people, we're particularly concerned, because particularly in states like California and Oregon and Washington, where recreational use is legalized, a lot of young people are finding access, even if they're not of age yet. And so it's really treacherous, and it's treacherous for the future of our kids and our teens.
Yeah. Similar to the liquor cabinet at home, right? It's legal, so it's not hidden or anything, and it might be locked up, but you'd be surprised how good your kids are at getting into things that you think.
That's right. Absolutely, no doubt about it.
Yeah.
Yep.
Well, and with that being even a possibility, and funny enough, I'm not really hearing a lot of people talking about this right now. You're very plugged into that research world and stuff, but I'm just not hearing as many like local general practitioners or even people, therapists. I don't hear a lot of people talking about this. And so I wonder if it's a potential landmine like alcoholism, if it's a landmine that someone might step on genetically that they don't know is there, and we amplify the number of people that are trying it out or experimenting with marijuana, let's put it this way. On a desert island with no alcohol, you could have a group of people, however big, and we'll never discover who has a predisposition to alcoholism because nobody's drinking.
Exactly.
Right.
Exactly. And it is, at least in my clinical experience, it is crystal clear to me that we are seeing young adults having psychosis would not have experienced it otherwise. And that's why we're utilizing that diagnostic category, cannabis-induced psychosis.
Yeah.
Because the common denominator is not occasional use, smoking a joint of leaves. The common denominator is smoking wax or oil chronically. By the time someone gets to our office, it's usually a year or more of daily chronic use of smoking wax and oils, and so or dabbing, as they say. And so that's that really strong common denominator that we're seeing. And it's terrifying. Dwight, you used the perfect word. I think it is a landmine. And as you also said, until you get to a higher level of care where people are being treated for psychosis, a lot of the clinical community isn't really super dialed into this as a landmine, and families in general are not. Non-clinical populations are definitely not aware of this as a concern.
When you've seen that with people, if they stop using, let's say they stop using cannabis altogether, does it tend to go away, or do they tend to be like struggle with this and be diagnosable with psychotic disorders? And what happens if they stop?
Yeah, well, that's an interesting question, because of course that is our clinical recommendation for anyone that comes in with psychosis. Now, what we often see is that, and we actually have a number of people that are struggling with this right now, is that if it is truly someone's first episode with psychotic symptoms, they tend to clear more rapidly, and the psychosis can really go into the background. Now, there's definitely no longitudinal studies about this. That'll be a whole nother area of investigation down the road. However, once we have someone who's returning for a second or a third or a fourth psychotic episode, the length of time it takes to clear and the degree to which they're able to clear at all is diminished. And like I mentioned, we have a handful of clients right now whose families are just devastated. Their loved ones are really not quickly reverting back to their humorous, clear selves. Their affect is blunted. They're fearful. They're responding, as we say, to external stimuli. It's not good. So the more psychotic breaks that occur, the longer they hang around and the less hope there is that they will clear entirely.
Wow. It reminds me, and as you're saying that, kind of like concussions. I've known people who you get a concussive disorder, or you get, they say the more concussions you get, the more dangerous it is to be more vulnerable.
That is completely true. That's another area that we do a lot of work with at my facility. And I hadn't thought of that parallel, but that is 100% accurate. It is of great danger when someone who has had a significant head injury, if they're vulnerable to having another one, particularly if it's close in time and proximity, it's very dangerous. It is a very similar phenomenon. You're absolutely right.
It makes me think whenever we have discoveries like this, and this is an ongoing discovery, it sounds like, obviously, because research is just kind of firing up. It makes me look back and say, how many people have I met over my career or my life who have psychosis as an ongoing struggle? And nobody ever maybe thought to ask about this, at least not for that reason. I mean, no healthcare provider has ever been like, yeah, go for it. Chronic marijuana use. That's a great idea. But
of course,
however, it makes me think, like, how long is that connection? Has that connection just always been there? Do we have chronic users who develop psychosis and they were always shunted into this little category over here, and we just assumed that it's
Dwight, that's a great question. I mean, I think the clinical presentation that we've always been sensitive to is sort of the amotivational syndrome to launch. That was what was considered more part and parcel of daily smoking, daily use, someone who just sort of stalls out in their life. But it's highly possible that people with psychosis were sort of moved over into the thought disorder community with that assumptive belief that this was an organic process, when in fact it was more related to daily use. Even prior to the distribution of high concentrates, there's so many different layers of vulnerability. So you've got folks that are highly vulnerable because maybe both of their grandfathers had psychosis, or their grandmothers, or whoever, or a parent. So the different layers of vulnerability change the complexion as well.
Yeah. Well, now it's another thing then to be put into a category that, and this is a problem whether or not it's marijuana driven or whatever, but the discrimination against schizophrenia or disorders that are identified as psychosis, if that's known, I mean, you start to take a certain identity on. I mean, people still hear schizophrenia.
Absolutely.
And they're afraid of violence, even though the population of schizophrenics are way less likely to become violent than non-schizophrenics.
Absolutely.
Even when you factor in that there's less of them. I mean, there's still less.
Yeah, no, you're absolutely right. That's a very common misconception. It's interesting. My experience used to often be that family members, parents in particular, experienced tremendous amount of internal stigma if their loved one had a thought disorder, had schizoaffective disorder or schizophrenia or bipolar 1 with psychosis. And that it was much less, much more palatable. Well, maybe this was substance induced. But now I'm seeing a variety of people with a range of reactions. There's so much stigma around the more severe levels of mental health disorders. And there's a lot of stigma around substance abuse. Right. So, like I mentioned
legal
earlier,
substance use sometimes. That's
even legal.
Another point of defensiveness people have is like, oh boy, here we go. He's another person telling me the devil weed and reefer madness or something like that.
Exactly.
A lot of young people watch reefer madness nowadays.
I've had a lot of parents who say this absolutely has nothing to do with smoking. That's ridiculous. This must be, over here. And it's just such a tough call. Yeah. And of course, we can never speak with 100% certainty. We have to always wait and see. Yeah. And that's where we'd much rather be able to speak in a black and white context, and we just can't.
But even the possibility, just even educating people to say along the same lines, and I think this hopefully can help people get around this fear of judgment or fear of like, oh, you're just another square who's telling me. It's like if we treat it like, oh, well, okay, so let's say that you're using marijuana, you've been using it this long or you use it this much. Even if you consider it to be one of your medications, we're evaluating all your medications. We're trying to say,
exactly,
this one might, did you know if you take this one and this one together, somehow someone missed that this causes this side effect and your main symptom is that side effect,
Exactly. Well, and going back to your previous parallel, it's similar to many years ago, I sort of stumbled over the fact that I had 3 out of my 4 grandparents had diabetes. And I had never known that. It wasn't in the sort of the folklore of my family, but I found that out. So although I didn't make any radical changes to my day-to-day lifestyle, I very much include that gently, if you will, in thinking, I'm very much going to enjoy a dessert or a sweet now and again, but I'm probably not going to do it every single night after dinner. And that's why I'm hoping that as we get the information out there, that cannabis can be another driver for psychotic disorders, that we can help people just gently be more thoughtful and be able to be more thoughtful for their siblings, their children, and so on and so forth. Yeah. It's not to create hysteria, but to really help people really, this is the best way to say it, to make a more informed decision.
Yeah.
No, I make an informed decision each time I decide to have dessert, as opposed to just not having the information.
Well, and when we look at what categorizes something as a problem, if we're talking about this level of high percentage use over a year or more time, which is really what you're seeing as the biggest correlation. There's generally speaking, from your mental health and physical, like your body's health, every aspect, mental as well as the other part of you. Probably need to look at that. I mean, that's not something. If you were drinking a box of wine every day, or a bottle of vodka every other day for a whole year, it's like there's probably something going on there that I should look at. Yeah, it's not healthy. It's not ideal, right? It's not something. Even if it wasn't also damaging organs, it would be something that'd be like, why do you need to be that checked out? What's going on?
Exactly. And to that point, oftentimes I find it's helpful to encourage family members and clients themselves to say, let's take a giant step back here. What is the bigger picture about? Why is this so important to you? Why do you have so much energy around this?
Yeah.
And then maybe try to deconstruct that aspect can be very productive because it engages people's critical thinking.
Yeah.
Why am I doing this? I never quite thought about it. Because if you're stuck in a power struggle, you're just busy defending your perspective instead of thinking, well, why am I doing this?
Yeah, no, exactly. And even, I mean, it's good to always kind of have an ongoing question about that. I was thinking as you're saying this in a setting, like take someone like myself who's just in a private practice, or maybe even someone in a small clinic that all they do, I don't prescribe or anything, but we do talk to people. One of the thoughts in my mind is how to apply this. If someone comes in who's having especially new or emerging psychosis they've never had before, and as far as I know, I mean, even their previous diagnosis might just be a mood disorder or generalized anxiety disorder or something like that. Oftentimes, well, now there's a new question to ask, right? It's like, well, hey, what's your use of marijuana like? Because there can be a correlation here. Knowing that means I might ask that question. As a consumer of mental health, that's another thing to say. If me or a family member starts getting that, I might want to be aware. Anybody listening to this, I'm just going to say at this point in the game, don't assume that your local therapist knows this or not knows that. Because I've just been learning about it recently, and part of it was because you're coming on the program and I'm doing the podcast.
Sure.
So not everybody's doing that kind of thing.
And it's not at all dissimilar from, someone who is a heavy alcohol consumer. They're not going to, walk into their brand new therapist's office and say, hey, by the way, you should probably know I drink a case of beer every night. In fact, even if they are forthcoming, they're probably going to require a little bit of probing to get to, what does one drink equal? Is that 4 ounces? Is that 12 ounces?
Well,
what is
absolutely. And oftentimes I always try to find ways to leave that door open to people to know, even if you told me that you barely drink, if you ever want to, I would never be disappointed by someone saying, well, I didn't know you that well 5 sessions ago, and now I'm ready to tell you I drink myself to sleep every night. Most therapists are going to be like, awesome, I'm glad you told me. It's like,
absolutely. Yeah, it's a formidable experience beginning a therapeutic process for anyone.
I remember reading a piece of research years ago, and it was talking about fetal alcohol syndrome and the risk factors. And one of the things they found was that many people, if they were asked, so first of all, they found that people, if they were asked, are you drinking while you're pregnant? Many of them would answer honestly, especially if it was
interesting.
Yeah, especially if it was in a questionnaire written format. Many people, maybe, I don't know, I don't remember the percentage, but many people will answer and say, well, however, when they surveyed to see how many doctors ask that of all of their patients, how many OBs do that, the results were practically none. Nobody's comfortable asking that question.
Kidding.
And I mean, it was some, it was less than, I mean, it was a very small percentage, less than 5% at least. And the idea that are we comfortable? And I think, to be honest, even in therapy, sometimes when people come in, it's like, Do you use any do you use any drugs or alcohol? No. Okay. But when I worked in an outpatient program, I found that you might say, do you use drugs and alcohol, or how often do you? But then you'd have to get a little more. Do you use pot? Do you use mushrooms? Do you use whatever you want to call it?
Yeah.
We wouldn't always say cannabis with our clients, but
right.
but that,
and even going, or exactly, or even sort of going in the back door by saying, so what do you do to relax?
Absolutely. Yeah.
That can be another way to encourage people to be more forthcoming. And then you're starting to respectfully honor. You might be doing a variety of things to relax, which is a normal human desire.
Absolutely.
And reducing that stigma a little bit.
And once again, a healthy desire. It's good. It's healthy to relax.
Exactly. It's healthy to want to relax. Absolutely. Yeah.
Where can people follow this research if they want to learn more and see the emerging stuff?
The bulk of the emerging research is through the NIM, M as in Mary, H, the National Institutes of Mental Health. That's the most trustworthy and the most robust source of research. So when I, go online to do a scholarly search, not, what does Dr. Google say this afternoon, but a scholarly search, and the NIMH research is available to the public. And so even if you don't have access to the entirety of an article, you'll at the least be able to see the abstract, which includes the hypothesis as well as the results.
Right. Dr. Google, by the way, is the only doctor my insurance will cover. So,
I know, right? I know.
At least at 100%.
Exactly.
But that's fascinating. And NIMH is also like a really good place just for mental health research in general. I mean, it's a good one.
Really anything that a person has curiosity about.
Yeah.
Going to find historical research as well as current day.
I would say anybody, if you're a fan of this program, for example, it wouldn't hurt to have it bookmarked. You probably would like it. You probably would find that it was good. Well, it's very, not only fascinating, obviously interesting and fun to talk to you, but it's also very important information as the world, whether people like it, love it, or hate it, the world is becoming more marijuana positive and aware. But this is an important part of that awareness, right? To say it's not just a wonder drug that everybody can do as much as you want and it's fine.
Right.
And, I don't know how many people think that, but just to be aware of the emerging evidence and emerging research that's done. And also for anyone out there, if your patients, your family member, yourself, if you're experiencing any increase in these types of hallucinations or delusions or these psychotic breaks, and that this might be a good thing to throw into the mix, to be aware of, like, what is my connection to this kind of thing. So when people come on the show, I always like to ask them, the first time they come on, I ask them for if they have a charity or anything they want to nominate or share with people. And you can certainly do if you want to. But the second time people come on, I like to ask them, is there any kind of mentally healthy or just joy-producing behaviors, actions that you like or that you would give as a little tip to people? Here's a way to increase your emotional mental health today.
Absolutely, there is. Our culture has gotten so exercise obsessed that people often think that in order to be doing exercise, that they have to go to a CrossFit box or they need to be riding a bike 100 miles. The number one thing I would say to answer your question is go for a walk. Walk if you're able to walk. Walk in the morning. Get your morning sunlight. 15 minutes, 20 minutes. Walk if you have a partner. Walk with your partner. Walk with your kids. Walk with your dog. Whatever that may look like, that if you are, if you're able to walk, and just movement. I don't know of any singular thing that can bring as much joy and personal comfort as moving one's body.
Absolutely. And we do tend to get this kind of all or nothing perspective. It's the other side. It's pros and cons of having a world where we can find so much information. I can easily find all the things I should be doing, but we forget that some is better than none, right? Even even a small amount, or some people,
really enjoy working in their backyard or really enjoy decorating their homes. And all of that can be movement. Cleaning house is a lot of work. And so if someone every Saturday, if they know they're going to clean their home, that's a workout. And I don't think in our culture of extreme activity that people really give themselves any credit for that or put onus on themselves when really they could walk around the block and their dog and their partner might enjoy it as well.
Well, tell people as well, where can they find you and follow your work and what you're doing with Awakenings with other
Sure.
things?
Well, Awakenings Treatment Center is online at awakeningstreatment.com. And our blog and our social media outlets are available from that site, awakeningstreatment.com. And our information is available there. All of our blog posts are there. We have some video information as well. So that is the best place to find what we're doing. Physically, we're located in Southern California, about 30 minutes north of Los Angeles, depending on time of day. We're in Agora Hills. We're right off a major freeway. And our clients come to us from the local area and from all over the country. We typically also have a small cohort of international clients as well. So people come to us from all over the world. We're a science-based facility. And so we're oftentimes what folks call the last house on the block, if you will. They've been to several other facilities and they're still struggling with whatever it is that they're dealing with. And they want to dive into it in a more science-based manner.
Gotcha. And excellent. And that's really the wave of the future is being more research informed and less. I mean, we've always, I think, in the corner of the industry that deals with some of these things, we've been kind of like, here's what we think works. And I've loved in the last 10 to 15 years, especially, I've seen a real uptick in, well, what does work and what should we stop doing and what should we do more of or start doing that we never thought of. So
exactly. We do a lot of internal research. So we're every month, every year, we're identifying, is what we're doing working in an objective and measurable manner? Different from calling someone 3 months after they discharge saying, are you still sober? But we're really finding out about the mental health components and what is continuing to improve at a 30, 60, 90, and 1 year milestones so that we can really identify what is working and what isn't. Yeah. So we're constantly making improvements as well.
It's a nice follow-up too. If I know I'm getting those calls and that you care, I'd be more likely to say, yeah, I'm having a hard time. Oh, well, maybe I should get some more treatment,
Absolutely. We have an alumni support system that is a big part of what we do. It's very special. Again, for people to not feel alone.
Very cool. Well, thank you again for sharing. Everybody out there, make sure to go check into these things, follow up, and use this information. I guarantee many people out there, if you think about it, there's probably someone or somewhere in your life that this is going to be useful knowledge. As you hear, just keep your eyes and ears open when people are having issues with psychosis. We should all be aware that this is one risk factor that's there. For those of you that are listening, once again, thank you for listening. You can always get involved with the program in multiple different ways. You can go to patreon.com/brokenbrain, or you can go to buymeacoffee.com/brokenbrain as well to contribute or to become involved with the program. You get some special bonus things like the video of all the interviews, this one included, that usually don't pop up anywhere. You can watch that if you choose, and also bonus episodes. One thing, I'm looking at my little calendar, I think this will be out before then. On August 31st, I'm going to be having the Broken Brain observance of International Overdose Awareness Day, and we'll be doing a live broadcast like I did last year. It'll be it's about a 4 or 5 hour long live broadcast with some different guests and segments and things. So tune into listen for that, and also tune into the social media. There will be a little bit before. There'll be a link dropping, and anyone who is a listener or is watching is welcome to click on that link and join the program as well that day. So that's an exciting thing that I'm really trying to get ready for, and excited to be able to do. And you, of course, Shari, you're invited as well if you want to be part of that.
Thank you. Thank you. I will be there. Thank you for letting me know about it.
Well, thanks again for being here.
Thank you for having me.
Thank you for listening to the Court and Parts Podcast Network. To listen to more Court and Parts shows, visit courtandarts.com.